Welcome back everyone for this course on somatic NGS and precision oncology. And I'm very sorry, on the first lecture there was some technical glitch and we started late. But happily, after that, during and after that, more than 1800 people have seen the video on the YouTube. And today we have Professor Akhil Kapoor, who's a medical oncologist, DM in medical oncology, and he works at a very high volume center at Mahamana Pandit Madan Mohan Cancer Center in Tata Memorial Center of Varanasi. And not only he has keen interest both in germline as well as somatic NGS, and he sort of dabbles in both and has vast experience in almost all solid tumors, adult solid tumors. So I thought he will be the best person to give an overview talk about what is the role of precision oncology and where NGS testing fits into the whole scheme of things. And just an overview. We'll not get into the details of every cancer site. So over to you, Dr. Akhil.
Thank you. Thank you, sir, for giving me this opportunity. And yes, as sir highlighted, this is an area where we need to understand a lot of things. It is not an easy job. Precision oncology is a concept which has evolved very fast in our country. It was relatively a new concept around 3-4 years back. But now precision oncology is the way to go. Everybody has understood, every oncologist has understood that precision oncology has definitely a very strong say in the management of patients. So let's say into it. I will try to give the key concepts actually. As sir highlighted, it is not possible to cover the entire topic, but it will give, I will try to touch upon the important points related to precision oncology. So, what is precision oncology? Definitely, we have understood cancer is a disease which is vastly heterogeneous. We cannot say one size fits all. Even chemotherapy are different for different cancers. Now, in a patient who is, let's take example of lung cancer, which is called the poster boy of precision oncology. A patient is treated with chemotherapy. One patient is treated with targeted drug called osimertinib. One patient is treated with under targeted therapy called alectinib, and another patient is treated with immunotherapy. So it is not a single disease which we are actually looking at. So we have the broad term called lung cancer, but we need to treat it, refine the treatment as per the treatment tumor's driver mutation. So that is what needs to be understood. How the disease is progressing, which mechanisms are involved in the progression of the disease. We try to identify that and keep that pathway under control so that the disease can be under control for a longer time with lesser side effects. And yes, the responses are sustained for a longer duration. So that is the key to understand about precision oncology. So yes, it is a targeted treatment focused on cancer driving mechanisms. It is integrating omics. So what is omics? It is omics means genomics. We are constantly utilizing genomics, be it germline testing, be it somatic testing. Now we are integrating proteomics as well. So and also we are integrating other omics data into our routine practice. So when all these are integrated, we get a better understanding of the disease, how the disease is progressing, and what we can do better for the patient's management. So this is what I try to highlight. It is not a single disease. It is a collection of diverse conditions, and each tumor is unique. Even not a tumor, every patient is unique, and we need to identify the mutation and treat it accordingly. And if we don't have any targeted therapy for that difficult mutation, specific mutation, actually the science is not yet advanced enough to treat that mutation. But after some days or some years, we'll definitely have some or the other treatment options. For example, just I will give an example of P53. P53 is seen in more than 60 to 70% of all cancer. In fact, much higher than that. But presently, we don't have any targeted therapy which is known to act on P53. There are some trials, especially in hematological cancers. The drug is called alziromandin, and this is under study. When the day P53 targeting treatments get developed and are effective, we'll see that 70% of cancers, at least, which are driven by P53, which is the most common mechanism of growth of cancer, the day will come where a lot of treatment will get improved and chemotherapy might become non-existent or been in supplemental role along with these P53 inhibitors. So this is what is precision oncology. We are moving towards that scenario where every patient, we do the genomic analysis or the omics integration, not only genomics, but proteomics and transcriptomics, and integrate it into treatment options. So just a very brief outline of the treatment options which are available in precision oncology. So it is a wide field. Small molecule inhibitors. This is just taking a simple example, which all of you might have heard, and most of you who are working in a cancer genetic setting will have seen as well. A patient with EGFR mutant lung cancer. The patient is being treated with osimertinib or gefitinib. Patient with melanoma having a BRAF V600E mutation, and patient being treated with BRAF inhibitors like dabrafenib and trametinib. So these are called small molecule inhibitors. These are tyrosine kinase domain inhibitors. These act on the cell surface of the cancer cell, and act upon it and inhibit the pathway. There is some multiple other drugs. The most important other one is monoclonal antibody. The best example is trastuzumab. So we try to treat all HER2 positive breast cancer patients with a drug called trastuzumab, which binds to the cell surface onto the HER2 receptor, which is already expressed on that cell. And we have identified by testing that HER2 is actually amplified in that patient. This HER2 testing can be by various mechanisms. It can be just an IHC. It can be even by NGS where amplification can be seen. It can be a test called FISH, fluorescence in situ hybridization. So there are multiple ways to test. When and how, we will learn gradually. It is a part of individual cancer. Then coming to let's combine a chemotherapy drug with monoclonal antibody, because what happens, so take an example of trastuzumab. The trastuzumab is acting and blocking the pathway of HER2. But let's try a mechanism by which trastuzumab, like monoclonal antibodies, binding to the cell surface and then delivering the chemotherapy directly into that cell. So this is like a rocket which is taking the payload and it is delivering it only to the HER2 positive cell, leading to less toxicity and more efficacy. So these are called antibody drug conjugates. So these deliver cytotoxic agent directly to cancer cells which are expressing that receptor. So this is example of antibody drug conjugate. We have seen multiple antibody drug conjugates. This is the after immunotherapy. This is the decade of actually antibody drug conjugates. The last decade was about the growth of immunotherapy. It is still evolving. We are still having multiple new trials of immunotherapy that is continuing, but this decade is about antibody drug conjugate, and we are seeing a lot of new antibody drug conjugates. One of the most potent antibody drug conjugate presently available, and that is specifically for HER2 positive cell, that is called trastuzumab deruxtecan. So deruxtecan is the chemotherapy component and trastuzumab is the monoclonal antibody component, and both are combined in antibody drug conjugate. There are multiple new emerging therapies, and this cannot be called a single class. This includes multiple drugs for HER2 for hormone positive drugs, hormone positive breast cancer, called PROTACs. So what is, they are directly degrading the proteins which are implicated in the tumor progression. So these PROTACs are under development, and some trials have already come. The drugs like camizestrant, drugs like elacestrant, which are used to treat ESR1 positive, hormone receptor positive breast cancer, that is the best possible example for such class of drugs. And further new drugs like vespidzant, and which are better, actually they are the typical PROTACs or receptor degraders. They are coming into action now. So moving, giving some more examples which are more familiar. We have just heard about BRAF600D. So one thing which I want to tell the students and the learners, that there are some mutations which are called tumor agnostic mutations. For example, if I see a patient with a BRAF600E mutation on an NGS report, I even do not need to see whether the patient is having glioma, whether the patient is having melanoma or colorectal cancer. All these will be treated nearly in a similar way with a targeted therapy. So that is called a drug which has approval from a basket trial or drug which is approved for tumor agnostic approval. So one example is BRAF 600B. Other very common example which is there is MSI high cancers. So any patient who has MMR deficiency, which is can be done, MMR testing can be done either on IHC or in NGS or also on other mechanisms by sequencing, where we find MSI high, that is mismatch repair genes are deficient. The patient is a candidate of immunotherapy. So that is approved irrespective of the tumor site, whether the disease in lung, whether the disease in colorectal cancer, whether disease in any other cancer. So in any MSI cancers, the drug is approved. So these are example of tumor agnostic approval. There is one more very good example. This is called NTRK. So the NTRK 1, 2, 3, these are basically fusions, and these fusions are detected by either NGS or there is a IHC also, pan-TRK IHC. On that, these molecules work very beautifully and they are approved irrespective of the tumor site. So this is again an example of tumor agnostic approval. And if we come to some other very familiar examples, I think all of you who have worked in genetics and genetic counseling field, or even in working, doing a PhD or a BSc, will have known about PARP inhibitors. So these are BRCA1 and BRCA2 mutations, which are very common in breast and ovarian cancers and also in prostate cancer. There are some specific drug group called as polyadenosine ribose phosphate inhibitors, polymerase inhibitors called PARP inhibitors. There are two very important drugs which are presently available, olaparib and rucaparib. Thankfully, both are the generic molecules, and that is why the drug is very cheap and easily available. The cost is hardly 2,500 to 5,000 rupees per month now. So that is why initially around 2 years back, we used to struggle to treat our patients with PARP inhibitors, but thankfully, due to the availability of the generic, the entire ball game has changed. That is why 2 years back, where we were used to find BRCA mutation, we used to think, oh, now I have found the mutation, but I am not able to treat the patient with PARP inhibitors. Thankfully, we are able to treat. One more thing, uh, things get evolved, the therapies get evolved with time. There are better drugs coming into action. For example, if you see an example of olaparib or rucaparib, these drugs act on both PARP1 and PARP2. So these are the receptors present on the cell, and PARP1 and PARP2 both are inhibited by these drugs. What happens? PARP1 is active on the cancer, but PARP2, it leads to myelosuppression. So PARP2 inhibition leads to reduction in hemoglobin, platelets, and WBC. That is why these PARP inhibitors have a tendency to develop myelosuppression. So what happens? We are not able to give full dose of olaparib or rucaparib to a large majority of our patients. 80% of our patients actually require dose reduction in the routine practice. So how to improve the action? So what happened with time, with as science gets evolved, we have now a drug which is acting only on PARP1. So that will lead to more action on the tumor, less action on the side effect. That means less myelosuppression, and the drug is better acting. So that drug is called saruparib, and those trials are already running at our center. So these are some of the examples which we need to understand. There are so many hundreds of examples in terms of targeted therapies and precision oncology that it can continue. Let's come to some of the examples of somatic testing. So when we do somatic testing, first of all, for precision oncology, you need to understand precision oncology needs to be it not only starts only with NGS. Precision oncology starts even with simple IHC. So if you are asked in your Viva or in any interviews, uh, how can you test for precision oncology if you want to incorporate precision oncology in the practice? It starts even with simple immunohistochemistry. So for as I had given example of HER2 is tested by IHC. HER2 amplification can also be tested by NGS, but IHC is one of the simplest way. Then other mechanisms include testing on germline, testing on other pathways like RT-PCR. For example, EGFR testing is still being done by RT-PCR, reverse transcriptase polymerase chain reaction. This can be done by digital droplet PCR, ddPCR. So all these are the mechanisms of testing where it can be utilized, and we need to understand uh, a combination of these might be required. Only one might not be enough. We need to supplement each other. We need to select the test optimally, and this is the work as a medical oncologist we try to do. We try to select the test. We take the help of our colleagues in molecular tumor boards. Molecular tumor board discussion is another specific area which will be covered in subsequent topics, and that is what is important. And also, that, as I was discussing about the omics, proteomics, and transcriptomics are also coming up presently in still in research, not very commonly utilized in routine practice, but yes, very coming into routine research part very actively. Liquid biopsy. So this is a very rapid emerging field actually. So if we take example of colorectal cancers, their ctDNA based testing from the blood is actually has got approval to, it helps us to decide whether the patient will require adjuvant chemotherapy or not. While there is also a study which is being recruited at our center after completion of adjuvant chemotherapy, whether there is any requirement of further intensification of the treatment based on ctDNA positivity or negativity. So that is the type of importance of ctDNA. This was a very tool which was very sparingly utilized previously. Now we utilize it very, very regularly. There is data that if we do both liquid biopsy and tissue based NGS at the baseline itself in lung cancer, they both complement each other and they both lead to improvement in detection of the mutations or targetable mutations, and also they help in finding the targets very rapidly. So they help us to complement. So sometimes liquid biopsy might supersede because liquid biopsy has able to take cells from all the cells in the circulation, while tissue biopsy, which you have taken a biopsy, you have taken a biopsy only from single site. While tumor can be heterogeneous, it can express one particular mutation at particular area, while it is not expressing that mutation in the another area. So that is the importance of a liquid biopsy, which is very rapidly coming up. There we try to integrate both liquid and solid tumor biopsies in terms of NGS. So liquid biopsies, that means ctDNA based testing, is also evolved rapidly, and it is now very routinely utilized in even routine practice as well. So as I discussed, we have come a long way in the last 1 decade itself. We are incorporating all these biomarkers in the practice for personalized cancer care for every patient. Every patient needs to be treated differently. For example, when I'm starting treatment of a patient with breast cancer, take an example of hormone positive breast cancer. What happens? I'm seeing at PIK3CA mutation, I'm seeing at ESR1 mutations. ESR1 gets evolved with time. It gets, but PIK3CA is a static mutation. We know that patients who are having PIK3C mutation in breast cancer, hormone positive cancers, they are not going to do well. So there are now trials which have shown that PIK3C inhibition from the baseline itself will help. And there is a drug called ivonalumab, which is already approved and is going to be shortly available in our country. So that is a part of personalized cancer care. Individual patient treatment will be difficult. It cannot follow a single rule that this criteria give this treatment, this criteria find this treatment. So this is a very, very individualized treatment which needs to be taken care of. It is not just a single treatment. And also there are many unheard answers. For example, if you see a situation in triple negative breast cancer, patients are treated with chemotherapy and immunotherapy in the neoadjuvant setting. That means before surgery, chemotherapy and immunotherapy is administered as a part of routine care. And after surgery, if the patient does not have a complete pathological response, that means the surgical specimen after chemotherapy shows that there is still a residual disease, the cancer is still present in the specimen. We need to intensify the treatment with multiple ways. For example, if the patient is BRCA mutant, you can give olaparib. You can continue immunotherapy, which was previously given. You can also consider utilizing capecitabine, which is a type of oral chemotherapy. So all these things are getting overlapped, and we need to decide which treatment is best for that patients. And sometimes more than one treatment is also combined actually in such scenario where the options are non-overlapping, non-toxic in terms of non-additive toxicity. So whenever you are combining some treatment, one treatment will have its own toxicity, other treatment will have its own toxicity. Combining the two might lead to more toxicity. So we need to check whether the toxicities are non-cross resistant, means immunotherapy has its own set of toxicities. Capecitabine, it has its own set of toxicities. So these two can be combined. But if both have similar toxicity, definitely it becomes difficult to be given to the patient. So all these things we need to integrate in the practice, and also accessibility and affordability. This is very, very important. This is what we try to do in every day of our practice. Though we talk a lot about personalized cancer care, but it is actually difficult to integrate these in the practice when the funds are an issue. And funds are always an issue for our patients, and we try to find ways and means to one of the best possible mechanism which we utilize is a cancer trial. Thankfully, for giving an example, we have 7 lung cancer trials in the first line setting where the patient gets broad panel NGS free of cost as a part of the pre-screening of a cancer trial. So that is one of the way we do a lot of somatic NGS testing in our practice through incorporation, recruiting the patient in a trial as a part of this screen. So just giving one more example, since the topic is very wide, it can be understood only through examples. Let's take an example of a KRAS G12C positive lung cancer. Till now, there was no cancer treatment approved in the first line setting, but now we have a trial recruiting at our center, which for that, this is just to be known, KRAS G12C is present in around just 3% of lung cancer in our country, while it is to the tune of 20% in Western population. In our country, EGFR is to the tune of 40-45%, while this is below 15 to 20% in West. So KRAS G12C mutation, we know these patients are not going to do well with chemotherapy alone. Something more is to be done. And these patients, we have a trial recruiting at our center. What happens? The patient gets an NGS as a part of this pre-screening for this cancer trial, and the patient gets an somatic NGS report, which helps us to decide for the treatment option. So patients can have any other mutation as well as a part of pre-screening, but we get to know the somatic part of the patient. Just coming to one more example, as we discussed, there are so many types of EGFR mutations, and we need to individualize treatment. It is not that EGFR mutations are all same. There are so many different types of EGFR mutations. We need to understand, we need to integrate the knowledge, and we also take help of our molecular pathologist in our molecular tumor board, the presence of whom is very, very essential. So now we have developed a concept when we are conducting any meeting or conference and there is a tumor board discussion, we keep two leads. One is a clinician lead and one is a molecular pathologist lead, or a lead person who has an understanding about these mutations. So this is a very rapidly evolving field, and this is an area where I think a lot of scope is there in future development in our country, because a lot of our doctors, even who are treating cancer, will not have adequate knowledge of treatment of these mutations, because this is not a very easy thing to understand and it requires a lot of expertise. Just giving an example of an uncommon EGFR mutation, if you see, this is a classical example of EGFR mutation where the drug can easily go into the socket. This is called EGFR socket. But if there is a alpha P loop helix insertion, the socket becomes smaller and the normal EGFR drugs which are there cannot penetrate that. Therefore, a separate kind of EGFR drugs like mobocertinib or poziotinib are needed. Also, there are some T7 and TM like mutations where the socket is again a much different, and the patient needs to be treated with a separate class of drugs, either osimertinib or sometimes other mechanisms. So it is a very different, even it is just an EGFR mutation. There are different types of EGFR mutations. These are called common, uncommon. There are some uncommon, common EGFR mutations and some common uncommon EGFR mutations also. So as we understand and delve into deep, the practice gets evolved. This is something about different mutations. I will give a clinical example as well now. So this patient of 752, a gentleman, the patient was evaluated for headache, nausea, and giddiness. And this patient was found to have, in the MRI, you can see there are multiple brain metastases. And also there is a lung lesion, which is a large lung lesion. So it is a stage 4 metastatic lung cancer. Biopsy was done. And this is an example of a foundation of an NGS, somatic NGS. And it was found that there is an uncommon EGFR mutation of EGFR E709K. So again, getting an information about which drugs will be active on this type of mutation, which is an uncommon EGFR mutation. We need to see the report in detail. Report interpretation is also an art, which we have learned gradually, but still we require help of our teams in molecular tumor board. and we need to discover which mutation will work, which drug will be active on which type of mutation. So this is just an example. We need to read about the mutations in detail. And if you see the EGFR 709K, it doesn't have sensitivity with first generation TKI, but has some sensitivity the second and third generation TKI. So this is example. Coming to this again, antibody drug conjugate, which we discussed. This is an example of TROP2 inhibitor actually. So TROP2 IHC can be done. TROP2 sequencing can be done on the tumor cell, and this drug is called actually sacituzumab govitecan, which is a drug which can be used for treating either triple negative breast cancer or urinary bladder cancer, where both the TROP2 expression is very high. It is again, as I discussed, antibody drug conjugate. So what is happening? This is the antibody which is binding on the cell surface, and it has also a payload. This is called SN38. This is a chemotherapy molecule, which is actually a topoisomerase inhibitor like irinotecan, which gets incorporated into the antibody, and this gets delivered inside the cell, which is expressing TROP2. So these are some of the examples of the trials which showed significant improvement in the outcomes with addition of these drugs. This is what I had previously discussed about trastuzumab deruxtecan, which is a drug, antibody drug conjugate, which is very revolutionized, significantly revolutionized our practice in even HER2 positive breast cancer, HER2 low breast cancer. So with evolution of the treatment, as the treatment gets better, we try to find more ways by which the patients can benefit. So this is called HER2 low. What happens? Patients who would have HER2 1 plus or HER2 2 plus, FISH is non-amplified, these are called HER2 low. This drug is effective even in those patients in breast cancer. So this drug is even approved in HER2 negative breast cancer, which are actually HER2 low or HER2 ultra low. So these are things, as we get better drugs, our understanding of the mechanisms and the biomarkers gets completely changed. 3 years back, HER2 low was never discussed. Now we are discussing about HER2 low to be incorporated in all our reports. So this is the data which we see of addition of the benefit in terms of overall survival, a significant improvement in outcomes, and these are already approved by various governments. PARP inhibitors we have covered and discussed previously. So after discussing so many things, so it seems it is actually very confusing. Now there are trials of every day. If you read about, if you have a in your email, you have activated your link for approval of drugs. Every day you get so many drug approvals. Whether these are actually meaningful in your routine practice, or whether they are just increasing the benefit of the treatment by 1 month, 2 months, and the cost of these treatments are also huge. So we need to understand the cost benefit ratio also. I will come to that very shortly. So just to summarize our treatment of metastatic TNBC, we need to see the PDL1. As I discussed, precision oncology, this is an important marker, PDL1. Germline BRCA is another very important marker, which we try to do in all patients with metastatic TNBC, germline testing. And if germline BRCA is negative, we need to utilize only chemotherapy. And if PDL1 is positive, there is a scoring ratio called CPS, combined positivity score, CPS more than 10. You combine it with drug called immunotherapy called pembrolizumab along with paclitaxel or nab-paclitaxel. So these are the approaches. And if you see, this is not only for metastatic cases, this has also come up for early stage cancers. So as I discussed initially also briefly, immunotherapy is now approved even in neoadjuvant setting. This means before surgery also, along with chemotherapy. And if patient doesn't achieve PATH-CR, that means that the disease is still present in the surgical specimen which has been operated. You utilize either capecitabine if patient is BRCA wild type. If germline BRCA is mutant, utilize olaparib, and along with the same, complete immunotherapy if the patient has received the same. So this is the one of the example to understand. Precision oncology is not only for metastatic cancers, it is there for early cancers as well. Immunotherapy is now being integrated in a lot of cancers in early stage in either neoadjuvant settings or adjuvant settings. So it is becoming more and more difficult to keep up with the data, and that is why we need to evolve. We need to have deeper understanding of the mechanisms. So now we're discussing, there are so many mechanisms and areas where immunotherapy is acting. But are there any markers of immunotherapy apart from PDL1? PDL1 is very commonly utilized. But let's see. There is one marker called tumor mutation burden. it is a tumor mutation burden needs to be done on a larger panel, at least 400, 500 genes actually, so that we can get idea of the new antigen load, because immunotherapy is acting on tumor new antigens, and that is why immune cell recognition gets improved. And the high TMB is also a marker for approval of immunotherapy irrespective of the tumor cell tumor type. Tumor mutation burden more than 10 megabases is a marker for higher chances of response to immunotherapy, though it is somewhat less utilized marker because it is costly to test for tumor mutation burden, but still it's a very useful marker. This is a positive marker, but are there any negative marker for response to immunotherapy? I have seen that patient is PD-L1 strongly positive, still patient is not responding to immunotherapy, so there might be some of the reason. So there is some genes like called STK11 and KEAP1 mutations, they are known to confer resistance to immunotherapy. So this is present in the tumor only. If we have sequenced a tumor by NGS and we have done a broad panel NGS somatic testing, we will know, yes, whether immunotherapy will act or not, whether what are the chances of response to immunotherapy. So this is based on the tumor pathway. So a tumor might have markers for increased responses to immunotherapy, and at the same time a tumor might have markers for resistance to immunotherapy, which we can understand if we are doing a broad panel NGS in the routine practice. Also, there's some other mechanisms which are not very well understood, that includes epigenetic modifications and tumor heterogeneity. These also contribute to poor responses. A very important marker which is very close to my heart, and we have done it as a part of our very important project at our center, is about gut microbiome as a important marker for response to immunotherapy. So Indians and Chinese have actually species in our gut. That means our GI system has a bacteria called Prevotella, and Prevotella is known to have somewhat poor responses to immunotherapy. There are some species which are known to increase the response to immunotherapy, and that is example is Akkermansia and Bifidobacter and Lactobacillus. So Lactobacillus, we all know. Bifidobacterium, many of us have heard, and Akkermansia is another very important species. We are trying to see if we are able to supplement and increase the gut microbiota with these positive species which are active. This is a species called Clostridium butyricum 5888 strain that has shown that responses to immunotherapy get improved from just 15% to 70% if we are able to just supplement that microbiome. And we have three trials, one in head and neck cancer, one in lung cancer, and another one in RCC, which are recruiting at our center to see how these patients will do with the supplementation of microbiome, and whether we are able to shift the immunotherapy benefit towards the positive side. So this is a very important thing, that we always think about the tumor, but it is the host microenvironment which is very important in the patient. If the patient has a tumor which is showing that it will show response to immunotherapy, there is a no KEAP1 mutation, no negative markers for response to immunotherapy, but still patient is not responding, so the reason might be there in the gut. So this is an important point, that we always blame the tumor, but sometimes it is the patient or our gut which is leading to non-response to the treatment. That is why there is a very important message that we need to keep our gut healthy by taking things which are healthy, and improving our diet pattern which are healthy for our gut, improving our gut microbiota. So this is very rapidly evolving, and we are having understanding not only in cancer, in terms of various other diseases, including trauma, including irritable bowel syndrome, and various other areas where the gut microbiota is recognized as a very important biomarker of response to any treatment and development of the disease per se. So again, I was just trying to highlight that there are some mutations which are very strongly actionable, but there are some mutations for which there is no clear-cut guideline to utilize that. So how we differentiate this in our practice as a medical oncologist, it is actually very difficult. As I discussed, when I wake up in the morning, in my email, I will see these two new drugs have been approved in the last 24 hours. So I get those mails. So how to decide whether the drug is actually useful in the practice or not, or how to act? So this is called actionability dilemma, and how to prioritize the drug practice. So this is a SCAT. This is a ESMO classification system which has led to a tier of information. So based on availability of a randomized clinical trial and actionability of the mutation, if there's SCAT 6, that means there is a tier 1 recommendation to have the drug in the routine clinical practice. There is a strong clinical data. Tier 2 is called, that is level 6 is called investigational targets, which have some promising action, but evidence is not yet complete. Some tier 3, this is again very important. For example, if I know BRCA1 mutation in lung cancer, we know BRCA1 mutation treatment is approved in breast cancer and ovary cancer, but there is no BRCA1 treatment approved in lung cancer. So this is called tier 3 mutation, where clinical benefit is shown in other tumor types or similar targets, but drug is not specifically approved in that cancer. So what we can do, we can utilize the treatment when the all other standard treatment options are exhausted. So this is very commonly understood in the practice. Some tier 4, that means preclinical. Some tier 5, we are co-targeting various mutations, and there is tier X where there's no evidence for that. So these help us to understand how we should take decision in the molecular tumor board and how the drug should be reimbursed in various situations. So these are all important points to understand. So just coming to one or more important points about ESMO magnitude of clinical benefit score. So SCAT told us which drug are actionable, which mutation are actionable. Now we need to see which drug have significant clinical benefit. So this is again a difficult area because, as I said, mutation is there, drug is also there, but is it worth utilizing that drug? We need to check a score called ESMO MCBS score. This is very simple score, and every one of you can just go log on to the ESMO website and check on the ESMO MCBS card. This is called ESMO, European Society of Medical Oncology, magnitude of clinical benefit scale. So what happens? There are two settings, curative and non-curative. Non-curative setting, the score is divided from 1 to 5. Highest quality of evidence for the benefit of the treatment is from 5 or 4. So the drugs which have the benefit of at least 3, they are utilized in the clinical practice. Below that, I don't think they are worth utilizing in the practice, either in terms of the benefit is so low, or if benefit is there, but it is having so significant toxicity that is impairing the quality of life, or also the cost of treatment is so high that it is just not satisfying the cost benefit ratio. So all these points take into consideration while we are deciding treatment for our patients. These are the evaluation guidelines. And that is why these take into various metrics like overall survival, quality of life data, toxicity data into the practice. So for example, if the ESMO MCBS score is high, the drug will be getting accelerated approval for high scoring therapies in Europe and even in US. And we try to follow the same in our country. We try to closely look at ESMO MCBS score of a new drug which has got approval, whether it is actually worth utilizing the drug or not. So these are now as last year, actually what happened, the ESMO MCBS was also version 5, version 2 has come, which is now incorporated hematological malignancy as well. So this is a new frontier which has been added. So to summarize, the area of precision oncology is very, very wide, and we need multidisciplinary team care where only one single oncologist is not able to take care of the patient. We need help from our various colleagues, including radiation and medical surgical oncology colleagues. Besides, our help from our pathologists, our genetic counselors, and also our molecular pathology teams, which are very, very important in terms of understanding the treatment. So all these are very, very important, and this is a teamwork. And this is acknowledgement to my dear mentors, and you can see Rajiv Sareen sir, who has helped us to understand the basics of these mechanisms, how we establish genetic clinics at our center, and now somatic testing understanding as a basic part for all treatment options. So this is my institute, Tata Memorial Center, Varanasi, where I practice, and I am very thankful to Rajiv Sareen sir again, and to his entire team for giving me this opportunity to give a brief talk on this aspect. Thank you. Thank you everyone for patient listening.
So thank you so much, Akhil. You really brought out the whole essence You took it from the heterogeneity in the tumor and why you have to know and deal with it and the various approach. So I think this was everything you covered. While you were talking, a lot of people were asking questions, and I answered some of those questions. They were mostly general questions. I will ask one other specific question someone has asked. What is the role of VAF in the report, which is a variant allele fraction? So again, this will be discussed in detail, but since someone has asked the question and others are seeing, so maybe just briefly you can talk about that.
Yes, sir. So as when we are seeing a report, molecular report, we need to understand whether the report is worth action or not. So there have been some cutoffs which have been established, which also depend not only on the tumor fraction, that means how much is the quantity of the tumor, but also how much it is expressed in the tumor. For example, if we see a case of EGFR mutation, the VAF is reported to be 10%, 20%. In some case, it is reported to 50% and above. Whenever it is going 50% and above, we become alert whether it can be germline or not. For example, if EGFR T7 NTM is identified with the baseline, VAF is more than 50%. So this helps us to give some idea about the actionability of the gene, and also whether how much is the tumor. It will also depend on the tumor content. So there are many things to that. Variant allele frequency is important. In somatic testing, we take a cut of roughly 5%. In germline, we take a cut of as low as 0.1%, depending on the depth of read. So these are the basic terms which we need to understand first. Then only we can understand the meaning of variant allele frequency.
So thank you, Akhil. Some other questions that have come. One is Piyush friend and from Job. So the question asked is, do you suggest comprehensive profiling at the beginning of the diagnosis, or you would focus on specific panel? That is the question.
Yeah. So this is again a area which is which where we need to balance the cost and the benefit of the treatment. For example, as I discussed previously, few years back, we used to think when we have only 9 actionable mutations in lung cancer, why we are doing 164 genes, why we are doing 500 genes. But now we understand we are able to find negative markers as well, which help us to predict whether the patient will respond to immunotherapy or not. So either you can do sequentially, first do a focused panel and later do a broader panel, or do a broader panel at the baseline. So just giving again example of EGFR. In EGFR mutation, previously there was a single treatment, osimertinib, or pemetrexed carboplatin plus gefitinib. Now we need to see if along with EGFR there is a mutation like P53 or concomitant PIK3CA or concomitant CDKN2A. All these are markers of poor response to EGFR inhibitor, where we need to combine it with either chemotherapy or use drugs combination like amivantamab plus lazertinib. So things have evolved so much that it has come from simple single gene testing or a panel testing to a large panel testing. So if cost wise it is feasible, it is definitely recommended to do a broader panel. If cost is not feasible, you can definitely go ahead with a smaller panel to begin with.
Okay. So other question I'll read out, Garima Gupta has asked, when we start immunotherapy and make the changes in gut microbiome, does that lead to another condition as well, like neurological? Then how do we mitigate the issue?
So it is not that after you are starting the treatment, the gut microbiome is getting altered. Gut microbiome is there from the beginning. So it is not a very dynamic situation. It is present from there. And when you are starting immunotherapy, your gut microbiome is secreting cytokines, which is able to either help the immunotherapy to act or not able to act. So that is the point which we need to understand. So gut microbiome has implications in terms of positive or negative modulation of responses to immunotherapy, not directly change of microbiome occurs with administration of immunotherapy.
Okay. So now one question someone has asked is, how to know whether a tumor mutation is a bystander or pathogenic? And let me just say that, there are a series of lectures. So many of these questions, they will be answered in much more detail. These topics will be covering in detail. But since you all have asked the questions and, Professor Kapoor is there, so I thought let us hear his perspective. So when they report a mutation, I mean, you have to take action upon it, whether it is bystander or the one which is actually driving the cancer.
Yeah. So again, when whether a mutation is a common, actually known pathogenic mutation or bystander, we need to see. It is more common in germ tissues with the testing where we are doing ctDNA based testing, where we keep on seeing the chip mutations. These are clonal hematopoietic mutations like IDH and other mutations. So it becomes somewhat difficult. But if your lab is expert, they can clearly just highlight in the report that this is likely to be a chip. That means clonal hematopoiesis of indeterminate potential. So these are well covered in the lab reports if the lab is of a good quality. And if we have doubt, we always take help of our molecular pathologist colleagues. They will help to understand, yes, that is a most likely a bystander mutation. And that is the importance of molecular tumor board. You can not directly just see the report and start treatment based on that. You need to understand the report. You need to interpret the report in a way. It is cannot be taught in a single day. It is an art which we learn with time.
Yeah, yeah, I think very well said. I'll just ask one more question someone has asked is that multi-gene panels. Huh? So you do for tumors. So why do we ignore pharmacogenetics? So because there's no other lecture on pharmacogenetics or pharmacogenomics, maybe Akhil, you can address as when you give chemotherapy drugs, do you have at the back of your mind that they are pharmacogenomic relevant variants?
Yeah. So this is important actually. We do integrate some of the pharmacogenomic markers which are already well established. Just giving an example of DYPD mutation, that is a dihydropyrimidine dehydrogenase enzyme, which is very important when we are treating the patient with 5-FU or capecitabine-like treatments. Some patients have DYPD heterogeneous. A very small percentage of patients have DYPD homozygous mutation, where the patient will develop life-threatening toxicities. So we are concerned about it, and wherever these mutations are well established, we try to incorporate in the practice. So this is not an uncommon thing. When we are doing a testing in colorectal cancer, we also send NGS. We also send DYPD mutation, where a hotspot panel is done to see whether there is a mutation in the DYPD genes.
Okay, so I think I'll just take one or two more questions. Otherwise, we can just go on and on. So one person has asked, how does the microbiome improve response rates? Your response to your treatment. So since you have done a lot of research on microbiome, you can elaborate on this.
Yeah. So this is an area of very strong active interest presently, because immunotherapy, if we see, by and large, it helps around 20% of your patients. What we can do to improve the response rates from 20 to at least 50 to 60% of the patient, this is what we are trying to find, microbiome modulation, because tumor characteristics you don't have control upon. You can somewhat modulate host microenvironment so that the drug can act better. So what happens, as I discussed, these strains like Akkermansia or Clostridium butyricum, these or Bifidobacterium or Lactobacillus, these release some positive cytokines which act on the gut to brain axis, and also these axis gets activated, leading to activation of the systems by which immunotherapy can act in a better way. The whole immunity gets activated in a proper way. The negative pathways are inhibited, positive pathways are stimulated. Drug can stimulate the immunity in a better way. So it is a very complex mechanism. It cannot be understood by most of us or even the scientists presently. But yes, it has already shown a very strong mechanism of response. Just giving example of a phase 1 trial in RCC, incorporation of CBM 588 like strain along with immunotherapy increase the response rates from just 17% to 70%. So see, your immunotherapy remains the same. You are just giving a pill extra, and thankfully those pills are very cheap. The cost is less than 2000 rupees. You are giving a 2 lakhs cost treatment per month. But if you are able to add 2000 rupees capsule, which is able to modulate your microbiome, so that the responses are going to be increased. So this is a complex mechanism, but yes, we are having multiple studies now in head and neck cancer also, because head and neck cancer is a very common problem in our country, especially in our area, and we are trying to act on it.
Okay, so just last two questions and we will finish. We'll come to, and all the whole lecture is on YouTube link, which will be again shared again, and all the chat is also there. So one person has asked that we have talked about genetic. What about epigenetic? And as a medical oncologist, when do you take epigenetics from the clinical perspective? Because the rest we don't have, not covering epigenetics. And the last question is, which I am not so that people have asked, the sample type, whether FFP or liquid biopsy, vary depending on the testing is done. So these two, and the context, in context of MRD testing or other context. So these two questions, epigenetics and what is the tissue type. And let me just tell, there's a separate lecture by molecular geneticists and molecular pathologists. They will go into detail. But as a clinician perspective, I'll request Akhil to give an answer.
So we just giving a usual example for epigenetic modification. This is most commonly seen in Lynch syndrome, where we have seen patients where there is no direct mutation in the MLH genes, but there is MLH1 hypermethylation. So that also leads to inactivation of the gene. So this is important when you are finding a strong family history, but you are not finding any mutations. You need to be alert that there is some other mechanism which is active and you might be missing that. In those cases, we try to get MLH1 promoter hypermethylation analysis and these testings. Apart from that, BRCA1 also. If you just see, BRCA1 methylation is also now a concept which has also evolved. So just to understand, briefly highlight, epigenetic modification is not so well understood in most of the cancer. We have understanding of few of the genes. Just giving an example of MLH1 gene, where we know there is already a documented MLH1 promoter hypermethylation, where the gene becomes inactive even after post-translation, and that leads to inactivation of gene, leading to sensitivity to immunotherapy and patient developing a chances of Lynch syndrome. So this is what is important. It might not be expressed in gene, but post-translational modifications might lead to development of these changes, which might have significant effects.
And the last one, do you bother what tissues type is available, when you prefer liquid biopsy, when you prefer on the FFP, or fresh frozen you don't get. So it is either FFP or a liquid biopsy.
Yeah. So sir, this is a very complex situation presently. As I discussed in lung cancer, now we have data to integrate both, because tumor is heterogeneous. If when you are targeting a biopsy, it will get a biopsy from only one particular area. And if you are able to get a liquid biopsy and also see whether it is similar to somatic NGS on tissue, that implications are different. In colorectal cancer, ctDNA based testing is already approved in terms of deciding the treatment. And we are doing a study in head and neck cancer, where the patient is ctDNA negative, then we don't incorporate chemotherapy with radiotherapy. If ctDNA is positive, we incorporate chemotherapy with radiotherapy in adjuvant setting. So that study is also going. So
and for MRD, what is your approach?
Yeah. So this is again a concept from colorectal cancer and some of the hematological cancers. So in ALL, if you take an example, patient is MRD negative. That means after induction chemotherapy, patient is MRD negative, minimal residual disease negative. You don't need consolidation with transplant, bone marrow transplant. So MRD becomes a very important concept in hematological cancers. In some other cancers, it is under study. For example, urinary bladder cancer, a study has been recently published where if patient is MRD positive, that is ctDNA based positive, you give atezolizumab as a adjuvant treatment. If it is ctDNA negative, you don't give atezolizumab. So these are also very fast evolving concepts.
So I think thank you so much, Akhil. You have covered a lot, and many of the question answers will be on the chat box as well as the transcript later on. And we'll end the talk. It's been an hour. It's wonderful. We didn't realize we have been listening to you and talking for almost 10-15 minutes discussion. So thank you. And I'm very happy to share that Professor Akhil Kapoor has agreed to, after these 8 lectures by faculty, there'll be 12 seminars covering each side. And he has agreed, volunteered to, moderate some of those sessions, not all. and see that when we discuss those individuals' cancer, like say lung cancer or colorectal cancer or breast cancer, which some of our trainees will be presenting and moderated by faculty. So he will play an important role. So thank you very much, and thank you all of you. You can later on go back and see the slide. And I think some of you did not get the link because every day how many mails we can send from that is limited. There are 1400 plus people who have registered. So sometimes there's a cap. You can send 1200 mails in a day. Gmail sets it. So we will send it. And we made a channel also. You please, in the mail that has gone, there's an invite to join that channel. You can't post questions there, but all these links and all will be on that channel, WhatsApp channel. Thank you. Thank you. Bye. My colleagues can end the meeting now.